Welcome to the session on reproductive health and indicators. In the previous sessions, we have learned about gender and health issues and women issues. Before we move into reproductive health, let us see the historical background. Since the mid-1990s, concept of sexual and reproductive health has evolved with a broad understanding of many factors such as gender, inequality, gender equity, reproductive rights, etc. that can affect the sexual and reproductive life of the people. Vision of sexual and reproductive health is traced back to the landmark 1994 United Nations International Conference on Population and Development, that is ICPD. International community has concern about population growth. Therefore, UN conference devoted this conference to population with delegates from around 179 countries and more than 1,200 NGOs met at Cairo and agreed a 20-year program of action to improve the sexual and reproductive health, foster reproductive rights and stabilize the world population. Reproductive rights include gender equity, equity empowerment of the women, and elimination of all kinds of violence against women, ensuring women's ability to control their own fertility. As we know, most of the time the women's fertility was controlled through family planning. But here there was an emphasis on gender equality, equity, empowerment of women. Sexual rights included right of all individuals, free of coercion, discrimination and violence to highest attainable standard of sexual health, including access to sexual and reproductive health care services, seek, receive and impart information on sexuality, sexuality education, respect to bodily integrity, choose their partner, decide whether or not to be sexually active. Then there was a consensus on the sexual relation, on the marriage, decide whether or not and when to have children, pursue a satisfying, safe and pleasurable sexual life. So you can see this program of action has a much broader concepts if we see the previous family welfare program. There is a link between fertility regulation and developmental goals in the context of human rights. We changed focus of the government and NGOs from classical population control policies and large-scale family planning program to recognition of needs and rights of the individual. Here the most emphasis was given on needs and the rights. It was not target approach like it was in the family planning program. In a paradigm shift, the ICPD replaced traditional fertility control program which emphasized demographic goals with a program of action. Program of action included a set of health services, education related to sexuality and reproduction, prevention of sexuality transmitted diseases, reproductive transmitted diseases, family planning, safe abortion, mental and newborn care. You can see previously the maternal and newborn care program was separate, STI RTI program was separate, family welfare program was separate and safe abortion were exclusively separate. But here all these things had come under one umbrella. United Nations in 2030 Agenda for Sustainable Development included universal access to sexual and reproductive health as a target. Commission on Sexual and Reproductive Health and Rights call for universal access to sexual and reproductive health comprehensively. Unlike previous population conferences, the Cairo conference reflected on population, poverty, health education, pattern of production and consumption, and the environment. All these had linkages. You can see it was intersectoral and multisectoral concept was adopted so that its health was not taken, reproductive and sexual health was not considered in isolation. Though the Cairo conference, the reproductive health and reproductive rights were defined and universally applied. Emphasis on sexual health as a result of HIV pandemic, sexually transmitted diseases, and as of public health importance, that is mainly violence against women and girls, has given importance to it. Sexual and reproductive health. As already I have told you, International Conference on Population and Development in 1994 has even given a definition on reproductive health. It is a state of complete physical, mental, social well-being and not merely the absence of disease or infirmity in all matters related to the reproductive system and to its functions and processes. Already in our previous session in Gender and Health, we have defined the definition of health. If you remember, it is a state of physical, mental, social, spiritual well-being, not merely an absence of disease and infirmity. Same way, they have defined sexual health also. Sexual health is a state of physical, emotional, mental and social well-being in relation to sexuality. It is not merely the absence of the disease, dysfunction or infirmity. Sexual health needs a positive, respectful approach to sexual relationships. Safe sexual experiences free of coercion, discrimination and violence. The sexual rights of all individuals must be respected, protected and satisfied. So you can see the sexual and reproductive rights have been given so much of importance because everyone has a right to decide about their sexual and reproductive life. Sexual and reproductive health implies a wide range of health issues. Already explained, like family planning, maternal and newborn health care, prevention, diagnosis and treatment of RTI and STI, including HIV, adolescent sexual and reproductive health. It is one of the most important component. Cervical cancer screening, infertility, prevention and management. You can see all range of diseases, disorders were included under the sexual and reproductive health because if you remember the life course perspective, if any girl had problem during adolescence, it will have impact when she become pregnant or mother and even during the old age. Sexual health and reproductive health overlaps. In addition to supporting normal physiological functions such as pregnancy and childbirth, aim to reduce adverse outcomes of sexual activity and reproduction. Enabling people of all ages to have safe and satisfying sexual relationship by tackling various obstacles like gender discrimination, inequalities, inaccess to health services, sexual coercion, exploitation, gender-based violence. These things are very common, not only in our country but most of the countries. So you can see sexual and reproductive health has given too much of importance. There should not be any inequalities, no discrimination. There should not be any gender-based violence. 5 core components of sexual and reproductive health are improvement of antenatal, perinatal, postnatal and newborn care. You can see when mother is pregnant during that period, during antenatal period, perinatal, postnatal, newborn. It's one of the very crucial time and it's very important to take care of all the aspects. Provision of high quality services for family planning, including infertility services. Elimination of unsafe abortion. Due to various reasons, due to teenage pregnancy as it was increasing, unsafe abortions were also increasing. Therefore, to provide facilities for safe abortion, not only to the elderly women but also to the teenage was one of the basic concepts. Prevention and treatment of sexually transmitted diseases including HIV, RTI, cervical cancer and other gynecological morbidities, and promotion of healthy sexuality. Because all these things have impact on the life of a girl and a woman and also of men and overall on the family. Sexual and reproductive health affects women and men, leading to ill health. However, men are also subject to sexual and reproductive ill health. They also acquire sexually transmitted infections including HIV and later AIDS. Men who have sex with men, including those who do not identify themselves as homosexual, contribute to the spread of sexually transmitted infections, including HIV, yet the health needs of homosexual and LGBTs are neglected. Even in our session on health issues of non-normatics, we have learned about LGBTs have their own set of problems and they are really neglected and healthcare services are not to the reach of these people due to various reasons. Although to persuade men to use condom is very difficult in various parts of the world, like studies have shown in Japan, Hong Kong, Singapore. For example, condoms are the main method of contraceptives, but it's very difficult to convince the men. In the UK also, where about half the couples wishing to avoid pregnancy are sterilized. Studies have also shown that involve men rather than women in improvement of sexual and reproductive health is difficult. Maybe due to customs, traditions, beliefs, due to patriarchal family concept. Need to involve men, particularly young men, in sexual and reproductive health is very important, but very little is being done to address their needs. So there is a need to see that it's not only the women or the girls who have sexual and reproductive health issues and ill health morbidities due to this problem, but it's also men are also affected. So that change has to come in the society, because overall if men will not be healthy, their productivity will decrease, the support to the family decrease, and they may have various morbidities and mortality will be high. Why sexual and reproductive health is neglected? That is a big question to answer about. So let us try to understand why it is being neglected. Studies have highlighted that sexual and reproductive ill health is a major cause of morbidity and mortality, with the exception of HIV and AIDS. This has failed to get support from the donors. Why donors do not support to sexual and reproductive health? So maybe some argue that the notion of reproductive health that was promoted in Cairo was too idealistic. That by emphasizing issues such as empowerment of women and reproductive rights rather than the provision of services, maybe they were expecting too much from this program or from the donors, because actually the health sector reforms, when they see the resources and the fundings, they are very particular about measurement of DALYs. Therefore, Some studies have highlighted that climate of healthcare reforms, that is, cut in the public sector, giving more emphasis on the tertiary care, involving contractual services, outsourced services, and involving private sectors are some of the health sector reforms decisions. And the climate of health sector reforms, the decision to use scarce funding are based on burden of death and disability attributable to particular disorder on the basis of measurements such as DALYs. Sexual and reproductive health is not only about disease but also about a collection of related health and human rights issues. And many people are still confused about what it consists of. You can see donors, they give money because they see what are the highest morbidity due to which disease, mortality and the DALYs. But here there are certain preventive issues, health education issues, human rights issues are associated. That's why they are a little bit confused and little reluctant to give money for sexual and reproductive health. Use of DALYs is not appropriate for quantification of the full burden of sexual and reproductive health. Pregnancy is not considered disease because it is a normal physiological process. Maybe there may be associated morbidities or some ill health issues can be there, or associated complications can be there, which are being poorly counted unless they result in the death. A stillbirth does not contribute even one DALY. Reproductive morbidities are often inadequately measured and are generally underreported because of associated stigma, or it is being considered normal. Suppose in various societies, if pregnant mother gets some issues or problems, it is considered as normal. If the mother is pregnant or woman is pregnant, she will have associated complications. That's why they are underreported and they are not measured properly. Moreover, DALYs only measures death, disease and disability without assigning any value to preventive interventions. Already I have told you, such as the family planning and to avoid ill health and promote well-being, including in the sexual matters. Sexual and reproductive health is an important aspect of individual health and well-being, but it also functions as a significant determinant of public health. Today, public health has given lots of importance to sexual and reproductive health. Therefore, if you see your own state or a country national program, so much of money is given to RMNCHA program, that is reproductive maternal neonatal child health and adolescent program, because it is an international or a global concern. You can see some links I have given here. You can go through these links, and if you are interested to read in detail, you can read these things in detail. Now let us see what are the indicators of sexual and reproductive health. 17 largely population based indicator provide an overview of the reproductive health situation at the global and the national level, endorsed by WHO and the United Nations. WHO resulting set of 17 indicators covered the main reproductive health areas and represent the consensus among international agencies and the key indicators for international comparison, global monitoring and follow-up to the International Cairo Conference. You can see these 17 population-based indicators were globally accepted without any change by all the countries, which in the long run actually has an advantage for international comparison and the global monitoring. One of the most important and the first foremost important is total fertility rate, that is TFR. Total number of children a woman would have by the end of her reproductive period if she experienced the currently prevailing age specific fertility rate throughout her childbearing life. It is one of the very crucial component because if TFR is greater than 2.1, the population in a given area will increase. If it is less than 2.1, the population in a given area will decrease, though it may take some time because factors such as age, structure, immigration or emigration are important factors which impact the total fertility rate. That's why if you will open any national program, first foremost indicator which is being compared is TFR. First set of findings from 5th round of NFHS conducted in 2019 and 20 was released by Ministry of Health and Family Welfare, Government of India. I have given the link. If you are interested, you can download this and go through the full report. Population Foundation of India has highlighted that India's population is indeed stabilizing as TFR has decreased across majority of the states because RMNCHA program is given lots of importance and it is being monitored very regularly. Second is contraceptive prevalence rate. Percentage of women of reproductive age group 15 to 49 who are using or whose partner is using a contraceptive method at a particular point of time. Maternal mortality ratio, that is MMR, annual number of maternal deaths per 100,000 live birth. It's also one of the very sensitive indicator and it is being targeted by, especially in our country. Antenatal care coverage. Percent of women attended at least one during pregnancy by skilled health personnel excluding trained or untrained traditional birth attendant for reasons related to pregnancy. If you see Government of India guidelines, it's very important for every woman to have 3 to 4 antenatal checkups during their pregnancy, that is by skilled health personnel who are trained, who are authorized to do the antenatal checkup or they are trained midwives. Percentage of birth attended by skilled health personnel. Percentage of birth attended by skilled health personnel, they exclude the trained or untrained TBA, that is traditional birth attendant. Skilled health personnel included all the doctors, all the nurses and even the auxiliary nurse midwife in India. Availability of basic essential obstetric care. Number of facilities with functional basic essential obstetric care per 500,000 population. If you see in our country the IPHS standard, Indian Public Health Standards, it is being now population based. Centers, your sub-center, PHC, CHC and the district hospitals cover the specific population because the facility has to be functional. Previously, before the NRHM came, many of our facilities were not functional although they were physically there. Functional means they will be open, they will have all the facilities and if mother or child or a newborn visited with the mother there, they will get all the basic facilities available there. Availability of comprehensive essential obstetric care. Number of facilities with functioning comprehensive essential obstetric care per 500,000. Essential obstetric care means it has to be given to every mother, and newborn care essential has to be given to every newborn. Perinatal mortality rate, number of perinatal deaths per 1000 total births. Low birth weight prevalence. It is quite common in our country, especially because most of the mothers, not only in the rural and the tribal areas but also in the urban areas, are anemic, moderately or severely. They do not eat properly during their pregnancy, and there are many other social cultural issues. So low birth weight, percentage of live births that weigh less than 2500 grams. Positive syphilis serology prevalence pregnant women. Percentage of pregnant women 15 to 24 years attending antenatal clinic whose blood has been screened for syphilis with positive serology of syphilis. Then your next is prevalence of anemia in women. Already I was telling you percentage of women of reproductive age group 15 to 49 screened for hemoglobin level with levels of 11 per gram for the pregnant woman and 12 for non-pregnant women. Then you can see percentage of obstetric and gynecological admissions owing to abortion, percentage of all cases admitted to service delivery point, not only for obstetric and gynecological service which are due to abortion, spontaneous and induced. Then reported prevalence of women with FGC, that is female genital cutting, which is quite common in various communities. Prevalence of infertility in women is also very sensitive indicator. Reported incidence of urethritis in men. So you can see HIV prevalence among pregnant women. This is a very sensitive issue nowadays. That's why every pregnant woman is screened for HIV. Knowledge of HIV related prevention practices. RMN-CHE and SDG, the multiple targets in SDG 3 and other goals refer to reproductive maternal newborn child health. These include targets for mortality, service coverage, risk factors and the health determinants. These are the links. If you want to go through in detail, you can read this. You will get the case studies and other data also. So in this session today, we have learned about sexual and reproductive health, historical background, issues and what are the international commitments which various countries have followed and the indicators which actually are comparable globally regarding sexual and reproductive health. Thank you so much.